Hello and welcome to the Doctor's Corner. I'm your host as always, Dr. Mark Pinsky, flanked by Dr. Ashish Udeshi from Florida Pain Management, and of course, my wonderful executive producer, Jeremy Gonzalez. Ashish, welcome to the show.
Oh, thanks, Dr. Pinsky.
Last time we spoke, unfortunately, we had just faced all this legislation, and we didn't really know how it was going to all pan out and whether it was really going to work. The legislation being how we would basically deliver opioid therapy and how that would impact our practices and how that would impact the patients. Before we go there, let's talk a little bit about you and Florida Pain and what you're doing normally during the non-pandemic times. Share that with the people.
Oh, sure. Not a problem. And thanks for having me back
My
again.
pleasure.
I appreciate it. I think we did this talk roughly 2 years ago.
I was trying to think. I think it is 2 years, but I'm getting old. I can't remember a lot of stuff now.
So, from that standpoint, our practice has grown, so I've still been with the group now almost close to 6 years.
Unbelievable.
In this area from having done my training at the University of Miami, and I've been with Florida Pain Institute since that time. We have 4 physicians in our practice. We have 7 to 8 nurse practitioners and PAs that also have joined our team throughout the years. And what we offer to our patients is still multidisciplinary treatment strategies suffering with chronic pain and targeted strategies and interventional approaches, as well as medication therapy for those that might need it. So we really try to find a comprehensive strategy to help patients that are suffering in chronic pain. That's what we do.
Right. And Ashish knows, the reason I have Ashish on the show is because I think incredibly highly of him as not just as a person, but I do think very highly of him as a physician. I think he is the epitome of what you would expect from a pain management physician. I think that he delivers not just procedural approaches to pain management as a lot of the people have done, but really does provide an integral approach. When I get his notes, it really is very well done and allows me to help the patients from a primary care perspective standpoint. And Ashish and I coordinate a lot of our care together. So I know from a more in-depth standpoint what he does and how he does it, and he really is an amazing guy. So I appreciate you.
Hey, well, I appreciate the compliments.
It's true.
But it's not just me. We have an incredible team at Florida Pain Institute, and we go every mile that we can to make sure that our patients are taken care of and get the feedback as well to the referring providers and understand that this is a team approach. It includes the referring providers, our team at Florida Pain Institute, but also the patient. We include them into the process. We educate them about their condition. We inform them of what the different treatments and strategies could be to help them. And that goes a long way to try to get our community better in the right way in trying to treat pain conditions.
So going there, I agree with all of that, but going there, you grew up here. So you are a hometown boy, which is, I do love that, by the way, because there's the misnomer that nobody that grows up in Broward County is ever bright. That's not true. She's proves that. And so having you here, and I know you're super involved in the community, which is also pretty amazing. We're appreciative of that too. So let's talk a little bit about the legislation, how the legislation impacted us back a couple of years ago, and what's really transpired. I can tell you from my perspective, it's definitely changed a lot on how we do things. I will tell you that unfortunately, the limitations of what we prescribe has been pretty dramatic. Not always a bad thing, though. I think it has woken us all up in the medical community as to thinking a little bit more before we just write and trying to really address the patient's issue before we do that. I think that's probably done that, for you as well. Yeah. Tell me from your perspective how it's changed.
Yeah, so I think when we last talked in 2018, there have been 2 significant guidelines or recommendations that had come out. One was the CDC Guidelines in terms of how to prescribe appropriately for patients, and we were focusing on selection criteria. There were some dose recommendations on what to utilize, and then also assisting patients with more alternative strategies for therapy. So that was one of those things that, at least in our practice, when we look for evidence or for guidance, how can primary care physicians, or even extending that out to the specialists, use some kind of guidance in terms of when we're managing patients with chronic pain. And I think that had set some limits sometimes for patients and what prescribers felt comfortable doing. Right. Again, they were guidelines. Some may have taken them more as mandates, but they were really just guidelines by the CDC. The other was the Florida legislation that we had talked about then extensively, House Bill 21, which really put legislation on what you could do for acute pain, and prescribing medications for anywhere from 3 to 7 days for patients when it came to controlled substance prescribing. And I think that legislation really changed how people practice. When it came down to acute issues for pain, they made indications for it, they limited quantity supplies, and really made the distinction between what was acute pain and what was chronic pain. for patients that were still suffering chronic pain, there was a misconception that they wouldn't be able to get their medications,
Right.
but that wasn't the case. It really just made sure that we were adhering to every single legislation that was there and every rule to make sure that patients got their medications appropriately, and that was written on their prescriptions that this is not for acute pain. And we were able to make sure that our patients were taken care of while also incorporating the CDC guidelines. So it was challenging, I think, initially for the patients because there wasn't a level of understanding of what's acute, what's chronic, and also for the providers in terms of how best can I still ensure that I'm providing quality care to my patients.
Well, and I totally agree with you. I think from my practice perspective, I do a lot of musculoskeletal medicine, and so we see a lot of acute pain. Yeah. And I think the data is pretty clear. The 3-day mark I don't think is reasonable, but the 7-day mark is pretty reasonable. And most of the patients do very, very well on that 7-day regimen. And most of them, at least of my patients, don't really want to be on it any longer. Where I run into problems a lot of the time is post-op, right? So post-surgical patients particularly, I think, have the most difficult time because they can only get medications for 7 days at a time, or at least that's what the surgeons tell me. Yeah. So I'm not sure that that's all true from mandate or if it's been true from just their perspective of what the mandate says. Do you know anything about that?
Yeah, so what I've learned, at least like you said, with the post-surgical pain patients, the mandate still, pretty much indicated, 3 to 7 days in terms of certain exemptions. But usually it was they would need to be reevaluated then. Right. And I think that was one of the things that was limited. It's not that patients can't be on medications longer than 7 days. It's that they need to be reevaluated. And I think that's what you're finding and some challenges initially with some of the surgical post-operative patients was, we have no problem that they're going to have continuing pain, and they may be having to go through therapy, which is one of the things that you find. Patients that might have acute surgery, and after surgery they have acute pain, they can give it a short supply of medications, but then for the next week or 2 weeks, they may need something to help them to get through therapy. Right. So I think the interpretation is, yes, you can get a prescription for 7 days, but that doesn't mean you can't be reevaluated and need medication again as you're going through that process. Right. And so with the acute post-operative pain, there's certainly a need because it's beneficial for patients, but you also need something to help them bridge as they get through that. And each surgery is going to be different, and each surgeon is going to have their own different regimen. And I think that was one of some of the challenges where they had to kind of change the tools that they were using before and look at different options. For instance, in the anesthesia realm, I'm a board-certified anesthesiologist, and what you found is that they were incorporating more regional nerve blocks in their cases and more local anesthetic in some of these cases that were longer lasting, and looking at ways that even preventatively, instead of using more opioids in the hospital, what can we do even when they transition out? So
makes sense. From a primary care perspective, again, because I do so much musculoskeletal work, really where the problem came in was the surgeon normally sees them 2 weeks post-op, right? And so I would usually see them a week after. Mm-hmm. Now, of course, what happens is they sign a pain agreement. So I got to get on the phone with the surgeon and say, hey, listen, are you going to do it or you're not going to do it? Yeah. I've reevaluated the patient. I kind of know. You just let me know what you want me to do. I'll give him another week. You just tell me how you want to do it. So again, I don't think it's necessarily a bad thing. It was good coordination between primary care and specialty. And of course, I'm big on that. I think that lack of communication is what creates most of the problem for patient and for provider. And we go back a little bit to the Marcus Welby days when you just communicate with one another and things go a lot better. What about in the realm of what's happened with opioid use? So you would think the logic would be, right, we've really cracked down. We've cut down on the pill mills. We've really done a great job. Has it really reduced opioid use?
Yeah. And so I was trying to research that and get the data in terms of what are we looking at our statistics from a national level, state level, or even county level. I wasn't able to get the most recent 2019 statistics, but just looking at 2017 and 2018 across the nation, I guess they had said, and I was looking somewhere, it was probably maybe less than 0.5%. We've seen a decline in opioid-related deaths potentially, is what they had looked at. But when you actually look at the statistics from 2017 to 2018, I think the counts opioid-related overdose deaths in 2017 was roughly 17,000. Now, overdose deaths in general, not related to opioids, was 70,000 at that time. And that's the number everybody tends to highlight because it's a larger number and a larger impact. In 2018, that number had dropped down to overdose deaths, not just opioids, to 67,000. And opioid deaths contribute around 14.5, maybe 15,000. So there was a decline in terms of prescription opioid drugs related to deaths. What that shows in 2019, I'm not sure what that trend is. When you looked at Florida itself, when they looked at those numbers of those 14,000, I think maybe they're seeing percent change. Nothing overly significant yet. Right. But again, that's only 1 year, and we're probably looking at a 2-year, 3-year trend in terms of that.
Yeah, and I agree, but I think there's a little bit of a skew in the numbers. Why do I say that? Now, if they break it down by prescription, different. Yep. But what happened is exactly, without getting political, which is exactly what they were talking about the border, right? The fentanyl use. You and I had actually predicted this. Yeah. We predicted that the heroin use would go up, and we predicted that the fentanyl use would go up. And that really is what happened. So in terms of opioid-related deaths, it's a little bit skewed because they just went out on the street to go get it. But I would really like to see what they did with the prescription stuff. I've got to believe that it really did make an impact. I just know from my own perspective and everybody that I talk to, most of the primary care guys are not writing very many narcotics anymore. If they are, it's very limited in quantity.
Yeah. And so looking at just Brevard County when it comes to opioid prescription deaths potentially, I think back when we first did this talk, maybe the annual rate was somewhere around 300 or more. In 2018, it showed maybe around 209, potential losses. Right. So there was an impact in terms of the prescription opioid. The other number that was very interesting to see was the number of overdoses that were non-fatal in Brevard County. So it's interesting to see. So how many people are actually being admitted as a result of overdose deaths? In 2017, that number was around, or 2018 actually was probably around 1,000. And that number may have increased to 1,200 the following year. But it's interesting to note, non-fatal overdose deaths. What does that really mean? It says that there weren't as many people dying, but they were getting seen sooner. And was it related to opioids or something else? But there certainly was a little pickup in that activity. But overall, prescription-wise, I know in our practice, we're adhering to the CDC guidelines. You have patients coming in saying, hey, I don't want to be on opioids. Right. That's the first thing that they will say. And we said, that's not our goal. Our goal is not to put you on opioid. So overall, the tone and what you're seeing, I think there's been a significant drop.
And I would agree with that. I mean, we get that in our office all the time. The first statement out of their mouth is, don't put me on opioids. Yeah. So I think that the press has been positive in the sense that this is the one time that the data has, I think, helped us in terms of getting the message out to how dangerous these drugs are. Yeah. And one of the things, I just got back from doing my mandatory CME stuff, and so when I did the mandatory CME, one of the things they talked about was how prevalent you hear people talking about it, but there's not a person that doesn't know that they're bad. Yeah. And yet in the 1980s, when these things first came out, they were, supposed to save the world, right? Purdue Frederick these things are non-addicting, and how all the legislation and everything bought into all that. And of course now we are now understanding and facing just devastation as a result of that. Yeah. I do think that the heroin use is up because it's really, really, really cheap. And I do believe that the fentanyl use, of course, coming from China has created a huge problem, particularly in Orlando and in Miami. But I do hope that eventually, we'll squelch a little bit of that. I think the pill use has gone tremendously down. I think the use of benzos has gone down. I think at least doctors are trying to put people on longer acting meds to prevent the yo-yo roller coaster effect that for some reason people who are addicted like. And so I think there's much more in terms of knowledge base, even in the primary care world. What do you see on the horizon here?
So when you look at it, I think there's a couple things. One, there was another House bill that was established back in just this year, or 2019, was House Bill 451, which required prescribers, before they prescribed any medication or controlled substance medication, or especially for pain, is to distribute a pamphlet. Right. And I don't know if you encountered this or not. Yeah. So before you prescribe any controlled substance of pain to patients, you have to give them a pamphlet. And I actually brought the pamphlet. I think last time I had a different pamphlet with me. but it was from the Florida Department of Health. And you have to give this out to every single one of your patients, and I may have put it in the car. But what it was is it tells you all the alternatives that they're there. Ah, yes. See, I carry one around in my pocket. I think last I carried around the CDC. But it said information on non-opioid alternatives for the treatment of pain. And so now it goes through all the different options that are available for patients. And this is a requirement, right? So like it touches upon the importance of education. And I think that's one of the things that I see in the future is more education towards this. You also see the formation of more task forces around this as well. There's the president had put out his Combat Opioid Abuse Task Force that had issued a sweeping guideline change back in 2018 of all their recommendations, 36 or more, very large document. The state of Florida also has their Florida Abuse Task Force as well when it comes to opioids, headed by the state attorney general, Ashley Moody, and her team of 21 people looking at ways to try to minimize the use of opioids as well as help people with addiction. Their website, I think it was called Dose of Reality. Florida.com.
I like it.
Yeah.
I like it.
But if you actually go on that website, it has good information for providers, for patients, locations and centers to get assistance. So there's a lot of good information that's coming out. So the future, certainly, I'm hopeful that we're taking all these guidelines, we're working collaboratively as teams. Brevard County has their Brevard Opioid Abuse Task Force as well. The Sheriff's Department, Sheriff Wayne Ivey and his team have been involved with that. Last year I think they had a big drug bust here in our local area, right, where they were recommended for their efforts that they did, over here in this area and seizing a lot of the legal narcotics, fentanyl, arms, what have you. So collaboration, I think, in this effort is going to be the future. I think that's collaborating with the primary care providers in terms of what's going on with surgeons, what's happening from the pain management perspective, but incorporating the patient, and then education as a community base.
Right. So I think your world has changed immensely, right? Your world changed from, in just a very, very short period of time, changed from just giving out pills to going to totally to procedure oriented. And now you sort of see this nice balance that's trying to come back in. Unfortunately, it needs to be more. And I think you're right. The education component, I think your group is very unique in that regard. I like the education. I'm big into that. I'm big into the talking to the patients. All the patients say that. They say, that the doctors all spoke to them. They all have a plan in place, and they understand what that plan is. Most importantly, the patients get better, right? We're realistic. I tell the patients, if I can half your pain, if I told you that today, the way you're coming in today, you would probably kiss me, right? Not now.
Social distance.
Jeremy, relax, social distance. But they forget that. So what happens is normal human nature is that when they get rid of that half that pain, then they want the rest. I get all that. But I think we are making huge strides by bringing in various treatment options, different types of things that are more conservative. And I think that the patients are responding to it. It's helped that a lot of the people in this community are very active, and that has also been a very positive thing. And I'm big on the weight loss front. So weight loss for patients, getting patients to move if they can't move on land, getting them to move in water is a very, very important thing for them. So I think we're making large strides in doing that.
I think also, to touch upon that, the insurance companies actually are now covering more services and minimally invasive options and funding research to try to look at ways as well as with medications, right? Before they would say, this abuse deterrent medication that's long-term may not be covered. They're opening up their plans and looking at it from that standpoint of what medication options are safer for patients too, because unfortunately some of the generic opioid pills are very cheap. But they're not abuse deterrent, or they don't have the long-acting safety technology that you are looking for. And now insurance companies are recognizing that. And then what you're seeing in the news, unfortunately, some of these pharmaceutical companies, have gotten hit hard. And hopefully some of the funds they get from these settlements go to some of the individuals that need medication-assisted treatment and work on strategies. So in the future, I think there's going to be more reliance on, non-medication options, more coverage from insurance about that, and more minimally invasive approaches and combined therapies, whether it's weight loss, diet, exercise, aquatic therapy, like you mentioned, as a comprehensive treatment, which I'm hoping more of those services will be covered too.
I certainly think that's the direction. I think, unfortunately, it is about money. right? And we don't often think about if we spend a little bit of money now, we prevent disaster, which results in cost savings later. And of course, a lot of what I do is preventative, and I really firmly believe that. An ounce of prevention is a pound of cure. And I really do believe all of that. And I think now that I've practiced this for 25 years, old now, Jerry.
Has it been that long?
This is actually my 24th year in Brevard.
Wow.
Yeah, it's hard to believe. But it is true that when I first started medicine, prevention or this concept of wellness was very obscure. And nobody really understood it. Nobody really talked about it. And traditionalists said it was crazy. And now I think we're starting to recognize the fact that keeping people well is the best medicine, and that you don't have to spend a lot of dollars on the back end trying to chase your tail when they're already sick. So, anything else did we forget?
No, it's pretty much, I think that's the update for now.
All right. I will continue to bring Dr. Udeshi back because you got some interesting technologies that we're going to talk about, which I was shocked by. I didn't even know. I found out a couple of months ago. So I do want to bring you back to talk about those things and what you have to offer. I think that your group is very unique in that and always on the forefront of what's happening in the pain environments. And the patients really need to know that so they know what's on the horizon. There's some people that are holding on to those dreams that there will come something that will be able to help them where modern medicine so far has not been able to. So we're going to bring you back to do that.
Well, I appreciate it. And also be on the lookout. The CDC may put out some new guidelines in 2021.
All right. Well,
so
we will bring you back and talk about that too if they do. All right. Listen, you can follow us on Dr. Mark's Corner at gmail.com. If you want to contact us and ask questions of Dr. Udeshi or myself, drmarkscorner at gmail.com. You can find us on pinskywellness.com. You can always find us when you go on pinskywellness.com. If you want previous episodes on the YouTube channel that's listed there, just click on that red button. It'll take you right there. We'd like you to subscribe to that and certainly share that with all of your friends and neighbors. Dr. Udeshi's contact will be on the bottom of the page. We sure do thank him so much for coming today. For Dr. Ashish Udeshi, for my executive producer, Jeremy Gonzalez, I am Dr. Mark Pinsky. You've been watching The Doctor's Corner. Take care. See you next week. This is Dr. Mark Pinsky once again, asking you to forward questions to us, whether regarding this episode or any of our past episodes, at drmarkscorner at gmail.com. Also, don't forget to check us out on our website, pinskywellness.com or pinskyweightloss.com. We look forward to hearing all of your questions, and we'll get back to you as soon as we do. Y'all have a great week.